classification of the potential causes of AUB, specifically that in the reproductive years. Its acronym is POM-COIN. POM for polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, wherein leiomyoma is subclassified into submucous, SM, or the other kind of myoma. Then we have the non-structural causes of AUB, which is the COIN. Could be coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. The uterine and ovarian arteries supply that of the uterus. These arteries become the arcuate arteries, then radial branches which supply blood to the two layers of the endometrium, the functional and the basal layer of the endometrium. Progesterone levels fall at the end of the menstrual cycle, and this leads to the enzymatic breakdown of the functionalis layer of the endometrium. And this breakdown can lead to blood loss and sloughing that makes up the menstruation. There's functioning platelets, thrombin, and vasoconstriction of the arteries to the endometrium that control this blood loss. So any changes of the endometrium, myometrium may cause AUB, and this could be because of a polyp, adenomyosis, leiomyoma, or a malignancy. A derangement to the clotting pathways, like coagulopathies or iatrogenic cause, can also lead to AUB, or disruption of the hypothalamic pituitary axis through ovulatory, endocrine disorders, or iatrogenic causes can also affect menstruation and can lead to abnormal uterine bleeding. So abnormal uterine bleeding could either be heavy menstrual bleeding or intermenstrual bleeding, and this can be further subclassified as POM for structural causes and COIN for non-structural causes. With the structural causes, or the POM, with a polyp, it's defined as AUB-P, or if it's leiomyoma, AUB-L, with SM for submucous myoma, and with O for other leiomyomas. For the COIN, it's the same. We have the coagulopathy as AUB-C, or endometrial as AUB-E. Let's understand how the endometrium responds to the two hormones that's affecting the endometrium, which are the estrogen and the progesterone. So we have estrogen withdrawal bleeding, when the bleeding after a fall or an abrupt fall in the estrogen levels, and this is when we see it in cases of bilateral oophorectomy or in estrogen replacement therapy, wherein there's a mid-cycle drop of the estrogen. Or it could be an estrogen breakthrough bleeding, wherein there's a chronic low levels of estrogen, then there's intermittent light spotting, or if there is a sustained high level of estrogen that can lead to prolonged amenorrhea, then sudden profuse bleeding. So this is in cases of chronic anovulation. With progesterone, when it's discontinued in an estrogen-primed endometrium, it's what we call progesterone withdrawal bleeding. And when progesterone levels are higher than the estrogen, there's progesterone breakthrough bleeding, where we see in patients who have been on progestins, only pill, or on DMPA, or on levonorgestrel intrauterine device. Let's look into the different causes of AUB. So we have large polyps that can develop ischemic necrosis at the apex, and this can lead to vascular fragility, chronic inflammation, and surface erosion, thus leading to AUB. Adenomyosis, where there would be endometrial glands and stroma extending into the myometrium, making the uterus enlarged and heavy, and this could be a possible cause of the AUB seen in patients with adenomyosis. Submucous and large, deep intramural myoma can cause an overlying stretch of the endometrium. So there could be compression from below and trauma in the intracavitary area, causing friction that can lead to focal chronic inflammation and ulceration that results to bleeding in compressed or damaged endometrium, as well as the hemostatic mechanism is impaired. In the presence of a myometrial condition, such as uterine fibroids, it is still not known whether endometrial disorders can lead to an impairment in normal menstruation, should be considered as a primary endometrial disorder that are independent of the myometrial condition. When we talk about primary endometrial disorder, this can include a reduced hypoxia affecting the coordinated endometrial repair, an increased inflammatory response after progesterone withdrawal, or a reduced hemostasis response due to an overactive endometrial fibrinolytic response, or a decrease in local vasoactive factors that could limit vasoconstriction of the spiral arterioles that can lead to excessive bleeding. An alternative unproven hypothesis is that the endometrium might behave in a manner consistent of a secondary endometrial disorder, in which changes occur in endometrial function as a consequence of the presence of a myometrial condition, like uterine fibroids or adenomyosis. There's also prolonged estrogen exposure, wherein an interrupted estrogen can stimulate endometrial proliferation. This can lead to abnormal thickness, wherein the tissue grows its own blood supply and becomes fragile. Without the growth-limiting and organizing effect of progesterone, these endometrium lacks the stromal support to maintain stability. Thus, focal areas break and bleed, while others heal with the continued exposure of estrogen. Others break down and bleed. Endometrial hyperplasia results from unopposed chronic estrogen stimulation. Histologically, they're proliferating glands of varying size and shape and a greater gland-to-stroma ratio. Lesions without atypia regress spontaneously with just curettage or with progestin treatment, and the risk for cancer, adenocarcinoma specifically, is around 1 to 3%. But for those with atypia, this is resistant to repeated curettage or high-dose progestational therapy, and the risk for progression to adenocarcinoma is 10 to 30%. In invasive carcinoma, there is stromal invasion. Coagulation disorders is also associated with AUB or severe bleeding. It's usually presented as cyclic, regular, heavy or prolonged bleeding, with heavy bleeding starting since menarche, and a history of postpartum hemorrhage or excessive bleeding after minor surgery. So coagulation defects happen in 10 to 20% of women with unexplained heavy menses. The Vaughan-Willebrand disease is the most common inherited bleeding abnormality affecting women. The Vaughan-Willebrand factor is a protein that plays an important role in primary hemostasis by binding to platelets. And this could also cause a formation of a bridge between them and adjacent platelet at the time of injury, or a carrier protein for factor VIII, prolong its half-life, and contributes to fibrin clot formation. Anovulatory bleeding is due to abnormal steroid hormone stimulation. So anovulation or oligo-ovulation could be because of a hyper or hypothyroidism, or it could be because of PCOS, hyperprolactinemia, hypothalamic dysfunction, nutritional deficiency, systemic illness, a chronic renal disease or liver disease, or even platelet dysfunction or stress. AUBE for the endometrial. It could be because of an endometritis from a postpartum or post-abortal period, or it could be an infection from a subclinical chlamydial infection, pelvic tuberculosis, or pelvic inflammatory disease, or it could be a placental site nodule. Symptomatically, it could appear as abnormal uterine bleeding, dysmenorrhea, dyspareunia or leukorrhea or urinary symptoms, and it may have some cases who may have some low-grade fever. Ultrasound, the two-dimensional ultrasound, would be difficult to be specific in the diagnosis of an AUBE, but there's really no pathognomonic signs for AUBE, but there could be associated symptoms like hematometria or endometrium with hyperechoic spots, or it could be a presence of intracavitary synechiae or an increase in endometrial thickness, which is asynchronous with the phase of the menstrual cycle. Hysteroscopically, the criteria proposed by Cicinelli et al. Has established the diagnosis of chronic endometritis, and this would be the presence of hyperemia because of the vascular network that appears accentuated, especially at the periglandular area, stromal edema, wherein the endometrium presents in the proliferative phase as both pale and thickened, and the presence of micropolyps, manifesting with small, pedunculated, vascularized protrusions of the uterine mucosa covered by the endometrium and characterized with accumulation of inflammatory cells like lymphocytes, plasma cells, or eosinophils. So it can appear with micropolyps, hyperemia, and stromal edema. For AUBI, medications affecting endogenous or exogenous hormones disrupting the HPO axis. This could be either a combined oral contraceptive pill, hormone replacement treatment, or levonorgestrel intrauterine device, or copper IUD. AUBN, not otherwise classified from the rest of the possible causes of AUB, and this is because of the presence of either an inflammatory cell release causing proteolytic enzymes that can damage capillary plexus and the epithelium, causing it to be fragile, causing microerosions. Or it could be a uterine AV malformation. So these are the different causes of AUB. This is summarized in this form, wherein at birth, it could be because of an estrogen withdrawal from the mom, foreign body trauma, infection, ovarian tumor, sarcoma botuloides, an ovulation at this age, coagulopathies, infections, or complications of pregnancy. During this time, from 10 to 50, it could be an ovulation, hormonal contraception, complications of pregnancy, infections, endocrine disorders, polyps, and myomas. The perimenopausal stage, it could be still the presence of polyps and myomas, but here there's a higher risk for endometrial hyperplasia or cerebral endometrial cancer. The older age group would be vaginal endometrial atrophy because of the low estrogen levels, hormone treatment, or endometrial cancer. To diagnose AUB, history is important to determine the extent of blood loss and its impact on quality of life. Up to 13% of women with heavy menstrual bleeding have some variant of the von Willebrand disease, and up to 20% of women may have an underlying coagulation factors. So other coagulation factor deficiencies like hemophilia and platelet function disorders may also be associated with AUB in any age group. So this could assist us in diagnosing the possible cause of AUB. So initial screen would be checking on heavy menstrual bleeding since menarche, or one of the following: a postpartum hemorrhage, surgical related bleeding, or bleeding associated with dental work, bruising, epistaxis, frequent gum bleeding, or family history of bleeding symptoms. On physical examination, the focus would be on the different signs of acute AUB and the possible etiology of the bleeding. Examination through speculum examination, pelvic examination, and bimanual examination is essential to identify the possible cause of the AUB. It could either be a trauma of the genital tract, and determine the intensity and the amount of bleeding. So other possible causes would be that of leiomyoma or adenomyosis. Diagnostics in the form of laboratory evaluation would be to check for the CBC, or the complete blood count, blood typing for cross-matching, and to rule out pregnancy. Then we can look into the possible disorders of hemostasis, partial thromboplastin time, prothrombin time, or activated partial thromboplastin time, and fibrinogen, or initial testing for von Willebrand disease if there's any suspicion for a possible coagulation disorder, the von Willebrand factor antigen, ristocytine, cofactor assay, or factor VIII. Another laboratory test to check for other ovulatory disorder that can be a cause of AUB, thyroid stimulating hormone, prolactin can also be one, serum iron, total iron binding capacity, and ferritin, liver function test, as well as chlamydia trachomatis to check for possible endometritis that could be a cause for AUB. Evaluating the uterus, as we have been consistently mentioning, that the uterus itself would be the cause of AUB. Either it could be structural, or the coagulopathy, or a derangement of the AUB of the HPO axis. So The endometrium could be assessed for the possibility of hyperplasia or malignancy. So a 2D ultrasound can be checked using this, can be used to check on this. Color Doppler or endometrial sampling wherein we can have a histopathologic diagnosis. Endometrial and cervical canal could be assessed for possible presence of polyps or submucous myoma. This is best checked with a sonohysterogram. Myometrium can be assessed using a transvaginal ultrasound, which has an 80% sensitivity and specificity for adenomyosis and leiomyomas. Color Doppler can be used to rule out arteriovenous malformation, or we can also check for the presence of isthmocele, which is a CS CAR defect. Endometrial sampling is advised for patients more than 35 years of age with risk of endometrial disease. And this is usually for patients of history of long-term unopposed estrogen exposure or a thickened endometrium. If endometrial thickness is less than 4 millimeter on ultrasound, it's unlikely that an endometrial hyperplasia is present in this patient. So for patients with abnormal bleeding lasting for more than 3 cycles, history has to be checked first based on its ovulatory dysfunction, gynecological disorder, a suspect of a possible bleeding disorder or medical disorder, examination for a suspect for ovulatory dysfunction like PCOS, insulin resistance, a possible presence of fibroids, polyps, endometriosis, or endometrial hyperplasia. This can be evaluated using this laboratory test, imaging, and additional test. So lab tests would involve CBC, iron studies, renal liver function test, hormone profile, thyroid, prolactin, androgen, FSH, AMH, coagulation studies, imaging, ultrasound, transvaginal ultrasound, sonohysterogram, MRI if there's really a need to document or to recheck, or additional tests in terms of endometrial biopsy, pap smear, or mammography. So on presentation with abnormal vaginal bleeding, the patient requires an initial assessment for pregnancy and determine that the bleeding is coming from the uterus and to confirm abnormal uterine bleeding. So bear with me here. When you have abnormal vaginal bleeding, evaluate cause of AUB, exclude pregnancy first, and confirm bleeding is really coming from the uterine cavity. If it's an acute or chronic, system 1 in a structured history, as we've mentioned, based on the frequency, regularity, duration, volume, presence of intermenstrual bleeding or unscheduled bleeding, then we look for the possible, or if there's a need for screening for coagulopathy depending on the history. System 2, we look into or investigate on the possible causes of AUB. Blood tests can be checked to rule out AUB-O for ovulation or C for coagulopathy. Imaging and visualization, what is usually used is the transvaginal ultrasound to rule out the presence of polyp, adenomyosis, leiomyoma, or those non-specified. Histopathology to document polyp and myoma, or even malignancy, clinical assessment for endometrium, and AUB-I, which is iatrogenic, or AUB-N, which is non-specified. Screening for medications as well, for possible medication use that can cause unscheduled bleeding. So for patients of high or heavy menstrual bleeding, this could be checked, iron deficiency anemia, as well as other anemia. Now, when patient comes in with acute vaginal bleeding, how do we approach this patient? There are 3 stages we have to look into. We have to assess rapidly the clinical picture, determine patient's condition. So assess signs of hypovolemia, hemodynamic instability. So we definitely have to insert large 2-bore IV needles. If there's a need for blood transfusion or clotting factor replacement, has to be done. We look into the possible etiology of the bleeding. So it's either if it comes from a structural or non-structural cause, and choose appropriate treatment. This patient needs a medical treatment or urgent surgical treatment. Medically, 2 main objectives here is to control the current episode of heavy bleeding, then to reduce menstrual blood loss and subsequent cycle. So we have an acute phase, then maintaining or chronic treatment of this patient to prevent recurrence of the acute episode of profuse vaginal bleeding. Treatment could either be conjugated equine estrogen at 25 milligrams IV every 4 to 6 hours for 24 hours. In this, there's actually 72% in 8 hours that bleeding will stop. Or you could use combined oral contraceptive pills to 35 microgram ethinyl estradiol 3 times a day for 7 days, 86% of reduction. Medroxyprogesterone acetate can also be used for 3 times a day for 7 days. 76% stopped bleeding in 3 days, with a median time of 3 days. Tranexamic acid could also be used at 1.3 grams per RM 3 times a day for 5 days, or 10 milligram per kilogram IV every 8 hours, with a maximum of 600 milligram per dose. There's reduction of bleeding in 30 to 55% of cases. So emergency measures in acute AUB include IV crystalloid fluid or blood products. An option would be doing an intrauterine tamponade with a French 26 Foley catheter infused with a 30 ml of saline solution. This controls bleeding successfully and should always be considered. Once the acute episode of bleeding has been controlled, multiple treatment options are available for long-term treatment of chronic AUB. And this could either be combined oral contraceptive pills or levonorgestrel intrauterine system, or even gonadotropin regulating hormone agonist or antagonist. There are 2 options in emergent treatment of acute AUB. So the first one could be a progestin therapy, where that is giving either medroxyprogesterone acetate nor ethindrone acetate. We have to remember that oral progestins are preferred compared to that of the levonorgestrel IUD or the intramuscular DMPA, because these have better efficacy. So MPA can be given at 60 to 80 milligrams 2 times a day till bleeding stops, then taper down to 10 milligrams every 4 to 6 hours. Or it could be given at 5 milligrams every 1 to 2 hours on the first day, then 20 milligrams per day for 10 days. Or norethindrone can be given as follows, as well as MPA-IM could be given as follows. Maintenance treatment could either be using GnRH agonist plus norethindrone add-back therapy, or progestin-only methods, which is DMPA or levonorgestrel intrauterine system, or even the progestin-only pill, or continuous combined oral contraceptive pill, using just the active pill. Option 2 would be estrogen treatment. Estrogen therapy with combined oral contraceptives or intravenous estrogen has proven useful. So as in the case of menstrual suppression, estrogen treatment for acute bleeding should be balanced against the elevated risk of venous thromboembolism. So CEE, 25 milligrams IV every 4 hours till bleeding slows, then combined oral contraceptive pills can be given or tapered, plus antiemetics. So it could either be the use of 30 to 50 microgram ethinyl estradiol component of a monophasic pill, plus norgestrel or levonorgestrel every 6 to 8 hours, then tapered down to maintain bleeding control. So if bleeding ensues, antifibrinolytics or tranexamic acid, intrauterine Foley catheter, balloon, and levonorgestrel IUD or curettage has to be done. Fewer risk and adverse effects than hormone treatment can be given, and this could be in the form of non-steroidal anti-inflammatory medications or the antifibrinolytic medications. So for the NSAIDs, this reduced bleeding by 20 to 40%, as well as relieving dysmenorrhea, as there's a reduction of prostaglandin levels. So this could be in the form of ibuprofen at 400 milligrams 3 times a day, or mefenamic acid 500 milligrams 3 times a day for 3 to 5 days. Antifibrinolytics can prevent fibrin degradation and decrease the production of tissue plasminogen activator by the endometrial cells or increase the rate of its clearance. However, this is contraindicated in patients with active thromboembolic disease. Most of the studies on the use of tranexamic acid in treating heavy menstrual bleeding have not included oncology patients, so making it difficult to assess the true risk of use of this in this kind of population. Okay. Now for AUB, for the treatment using hormonal medications. The goal for hormonal treatment would include suppressing endometrial development, reestablishing predictable bleeding patterns, and decreasing menstrual flow. So combined oral contraceptive pills can be used cyclically or continuously to control normal uterine bleeding due to ovulatory dysfunction. It can reduce menstrual volume by 40 to 50% and decrease dysmenorrhea. So anovulatory women who needs contraception will be best given with estrogen-progestin treatment in the form of monophasic oral contraceptive pill. For acute bleeding, as we've mentioned earlier, high-dose estrogen-progesterone treatment, provided endometrium is normal or thick. So high-dose COC can control also heavy bleeding. So for COC, which contains 30 to 35 microgram of ethinyl estradiol in that component, it can be used 3 times a day for 48 to 72 hours, then taper down. For COCs with 20 to 25 microgram ethinyl estradiol, 4 times a day of these medications can be used and taper down as well. So the use of progestogens. Progestogen may be used in the following cases wherein estrogen is contraindicated, especially for patients with cardiovascular risk factors or with a history of deep vein thrombosis, or when patient declined the use of estrogen. Withdrawal bleeding may be more predictable with cyclic progestin treatment as well. So this could be in the form of medroxyprogesterone acetate at 10 to 20 milligrams per day, or norethindrone acetate, micronized progesterone 200 milligrams per day, drospiridone or combination of drospiridone and norethindrine, or depomedroxyprogesterone acetate at 150 milligrams every 3 months. The purpose of progestogen is actually to decrease the endometrial proliferation and induce decidualization. The use of levonorgestrel intrauterine system is very effective. It was around 97%. As we all know, it is a powerful anti-estrogen stimulating 17-beta-hydroxysteroid and sulfotransferase activity that converts estradiol to estrone sulfate, which is rapidly cleared from the body. It also inhibits estrogen induction of its own receptors, estrogen receptor replenishment. It also suppresses estrogen-mediated transcription of oncogenes. Thus, progestins have anti-mitotic growth-limiting effect on the endometrium. So in oligo or anovulatory women, withdrawal bleeding induced by cyclic treatment with progestin in the form of MPA 5 to 10 milligrams once a day for 10 to 14 days every month can be useful. Levonorgestrel in women deemed at risk for endometrial pathology will be best for patients for this purpose. So aside from using estrogen, progestin for long-term use, there's also benefit in using GnRH agonists or antagonists. The purpose or how it acts is basically to suppress the ovarian hormone production that can lead to the atrophy of the endometrium, reducing bleeding. So it could be in the form of leuprolide acetate, triptorelin, or gossaridine at 3.75 milligrams monthly or 11.5 milligrams every 12 weeks. An add-back therapy will benefit this patient because of the hypoestrogenic effect of the GnRH agonist. Advantage of the use of GnRH is there's no prothrombotic risk with high rates of amenorrhea, around 96%. GnRH antagonist is also being advised now. It can be given orally in the form of elagolix at 300 milligrams 2 times a day for 6 months, with or without add-back therapy. There's a 50% reduction of blood loss and 68 to 76%. The benefit of using antagonists is there's an immediate suppression of gonadotropins compared to that of GnRH agonists when there's actually around 7 to 14 days because They initially cause a surge in the LH and FSH, then eventually desensitization of these levels before it really goes down. Another possible medical management would be danazol, as it reduced menstrual blood flow as it caused endometrial atrophy. However, this is not frequently used because of its androgenic adverse effect. They say that we can lessen the effect by using lower doses or a vaginal formulation of danazol. However, to be effective, danazol must be used continuously for about 3 months. This is usually used only when the other forms of therapy are really contraindicated. Now, medical management, we've discussed it with either using the non-hormonal medication in the form of NSAIDs or tranexamic acid, then the hormonal in the form of estrogen, progestin, combined oral contraceptive pills, or the GnRH analogs. Now, if patients, there are some cases, especially that of structural cause of abnormal uterine bleeding, wherein medical treatment will not be beneficial for them or will not treat the problem. So we now offer surgical management for this patient. Surgical management would include dilatation and curettage. This is the fastest way, especially for patients of acute bleeding, to stop acute bleeding, as there is surgical denudation of the basal layer, stimulating the normal processes then of local clotting mechanism, vasoconstriction of the basal arterioles, and re-epithelialization. It's not just therapeutic by stopping acute bleeding. It could also be diagnostic, as we will be able to see histopathologically what's the possible cause of the abnormal uterine bleeding. However, with DNC, it's done blindly. To improve diagnostic accuracy of the lesion, hysteroscopy is offered, especially for patients with polyps and submucous myoma, to excise specifically where the polyp and the submucous myoma is located. In cases of patients who are not desirous of pregnancy, endometrial ablation can be offered for patients who have chronic AUB. This could either be through laser, rollerball, or resectoscope, thermal, or freezing. Bleeding is controlled in 60 to 80%. Or we can have uterine artery embolization, wherein fluoroscopy is used to visualize the fibroids. Embolic particles are injected through the femoral artery to occlude blood supply to the fibroids. So uterine artery embolization is also being done for patients who are not desirous of pregnancy. The myomectomy can be done hysteroscopically for submucous myoma, or laparoscopy or laparotomy for myoma which is outside, that's intramural or subserous myoma. Hysterectomy, if all fails, or if the patient is not desirous of pregnancy anymore, or there has been continuous bleeding even with hormonal treatment or other treatment, then hysterectomy could be an option. For endometrial hyperplasia, in premenopausal women, MPA can be given at 40 milligrams orally for 3 to 6 months, or we can insert levonorgestrel intrauterine device. Repeat sampling after 3 to 6 months to check if there's any atypia or progression into a carcinoma. With resolution, a cyclic MPA of 5 to 10 milligrams for 10 to 14 days. So cyclic progestin treatment should be given. If persistent, hysterectomy is offered. In menopausal women, patient may proceed on having a hysterectomy. For coagulation disorder, specifically that of the von Willebrand factor disease, an desmopressin can be used. It's an analog of arginine vasopressin that promotes the release of the von Willebrand factor from the endothelial cells storage sites. And this treatment can induce a rapid increase in the coagulation factor 8 and the von Willebrand factor that lasts 6 to 12 hours. So treatment should be started on the first day of menses. It can be administered intranasal inhalation, intravenously, or subcutaneously. So this agent, though, must be used with caution because of the risk of fluid retention, or hyponatremia, and should not be administered to patients with massive hemorrhage or receiving IV fluid resuscitation because of the issues of the fluid overload. Recombinant factor 8 and von Willebrand factor are also available and may be required to control severe hemorrhage. Other factor deficiencies may also be needed for factor-specific replacements. But patients with bleeding disorders or platelet function abnormalities should avoid non-steroidal anti-inflammatory drugs because of their effect on platelet aggregation and their interaction with drugs that can affect liver function and the production of clotting factors. Antifibrinolytic therapy is an alternative as it prevents clot dissolution, particularly in the mucous membrane like the endometrium. Combined oral contraceptive pills or levonorgestrel intrauterine system help reduce the volume and duration of menses, especially in women with the von Willebrand disease. For chronic endometritis, wherein specifically it's more common in patients who have infection, we can choose an expectant management wherein if chronic endometritis is just an incidental finding, we can just monitor. Or we can give antimicrobial treatment when there is accompanied abnormal uterine bleeding, pregnancy loss, or infertility. So medications could either be doxycycline, metronidazole, ciprofloxacin, or letro, or it could either be a combination of these medications. There's a new technology that's being offered, which is a non-surgical option for, especially for patients with adenomyosis, adenomyoma, or leiomyoma. It's a non-invasive treatment of tumors in vivo that can effectively destroy the target tissue without damaging the path of the ultrasound beam and surrounding normal tissue. So the ultrasound beam can penetrate into the deep tissue and cause protein denaturation and irreversible cellular death via coagulative necrosis in the target tissue using thermal energy. So this is one of the primary mechanisms of HIFU. The second mechanism is an indirect effect of HIFU through inducing necrosis or embolism of nutrient vessels of the target tissue that obstruct the vascular supply, inhibiting its growth. So what's good with HIFU? There's no surgery needed. Patient has to be slightly awake for them to feel the heat when the beam is being focused on the affected area. It's quite effective. We've been using this in our center, and it has shown good response among patient and a very efficient decrease in the size of especially for patients with adenomyosis and adenomyoma, wherein surgery may be more difficult in these cases. So the summary and the management of AUB, as we want to check first the cause. So we have the palm coin. For polyp, this cannot be treated medically. A DNC or hysteroscopic resection has to be done. For adenomyosis, this can be initially treated medically by giving levonorgestrel intrauterine system, giving GnRH agonist. HIFU can be an option for this patient. Adenomyomectomy, or if it's not really possible, or all medical treatment is not working, hysterectomy may be an option for these patients. Leiomyomas, GnRH agonist can decrease the size of the myomas. HIFU can also be an option. Hysteroscopy for submucous myoma, myomectomy. It could be we could use endometrial ablation or embolism, or if there's really a problem or the other medical or surgical treatment is not working, hysterectomy would also be another option. For patients who have malignancy or hyperplasia, endometrial curettage to diagnose or get the histopathologic diagnosis first, high-dose progestins, levonorgestrel intrauterine system. If there's really a need, hysterectomy or radiotherapy for malignancy. For coagulopathies, tranexamic acid, desmopressin, especially for patients with von Willebrand disease, levonorgestrel intrauterine system to decrease menstrual bleeding, combine oral contraceptive pills continuous also to decrease menstrual flow or no flow at all. For patients with ovulatory dysfunction, these are patients who have like PCOS or hypothyroidism or obese patient. Lifestyle change will definitely have beneficial effect for this kind of patients. Correcting hormone dysfunction, use of combined oral contraceptive pills or progestin-only pills if there are some contraindications in the use of estrogen in these patients. For endometrial disorders, as it has been associated with endometritis, antibiotics will be beneficial. For iatrogenic cause, we have to identify the possible source and shift the treatment. For those not otherwise classified, it's usually associated with endometritis or AV-mal. So we could use antibiotics or embolizations for arteriovenous malformations. Now let's look into different cases on how we can approach these patients in terms of diagnostics as well as the management of these patients. So for the first case, we have a 32-year-old G0, newly gravid, with profuse vaginal bleeding for a month. She's desirous of pregnancy. Since patient has profuse vaginal bleeding, we want to stop the bleeding immediately. So we'll start first with the least possible side effect. So giving tranexamic acid as well as mefenamic acid. So tranexamic can be given at 500 milligrams 3 times a day for 7 days, and mefenamic acid at 500 milligrams 3 times a day for 3 to 5 days. As we've mentioned earlier, NSAID reduce bleeding by 20 to 40%, relieves dysmenorrhea as it reduces prostaglandin levels. So it could either be mefenamic or ibuprofen that can be used. So once we don't want to give any hormonal treatment first because we're not so sure if it's a problem with estrogen or progestin. So transvaginal ultrasound is done. And here, there's a submucous myoma that was seen around 2x2 cm FIGO type 1. So there is an encroachment into the endometrial cavity. So we definitely know here that hormone treatment or medical treatment in terms of progestin or estrogen is not an option. The best way to treat this would then go for a hysteroscopic resection of the myoma. So hysteroscopically, this is the submucous myoma that's seen through the scope. So final diagnosis for this patient, AUB, leiomyoma, SM for submucous. Case 2, a 55-year-old, so older patient, G2P2, with a BMI of 30, so patient is obese, with profuse vaginal bleeding for a month. First, we have to stop the bleeding first. We don't give hormone treatment first because we want to be sure, we want to check on the endometrial thickness. Basically, we want to do an ultrasound first to check if the endometrium is thick or thin. So to stop the bleeding, immediate stop, we still give the tranexamic and the mefenamic acid. Now, an ultrasound was done, which showed an endometrial thickness of 1.9. That's quite thick. We want the endometrial thickness, especially for patients who've been bleeding for almost a month, to be around less than 4 probably. Since reproductive, it could be less than 7, could still be acceptable. Patient showed a bulky uterus to consider adenomyosis. Ovaries are normal with follicles. So we can see here that the main problem for this patient is adenomyosis. We have to rule out the possibility of malignancy, and it could be a possibility of ovulatory dysfunction, as patient's thickness of the endometrium is not consistent with the small follicles that is seen on the ovaries. Because if you have a thickened endometrium, we expect that the patient already have a corpus luteum, as patient will now be having her menses soon. So how do we manage this patient? Since patient has a thickened endometrium, we want to be sure if we're not dealing with any cases of carcinoma first. So we want to do an endometrial biopsy. It could either be an office endometrial biopsy initially, or we can advise this patient to go directly to DNC or hysteroscopic guided biopsy. So once we do this, if after doing all this procedure, we wait for the histopathologic report. If it's just a hyperplasia without atypia, or even with patients with atypia, levonorgestrel intrauterine device can be inserted. Since this patient is not desirous of pregnancy, then the levonorgestrel can be used as a progestin pill to prevent them from having a thickened endometrium again, because this patient most likely have chronic exposure to estrogen. Now, this is another case, a 32-year-old G0 with heavy menstrual bleeding, FIGO type 2 with leiomyoma. So this patient proceeded, as we've mentioned, as we've seen earlier, also with hysteroscopic resection of the submucous myoma. I just want to point out here that you can actually form a chart like this. So we have a palm coin with a yes or no. Since patient don't have polyp, no adenomyosis, with the presence of myoma. Malignancy, no. Coagulopathy, ovulatory dysfunction, endometrium, idiopathic, and not classified. Now we have a 25-year-old G0 with a BMI of 33 with irregular menstrual bleeding. We have a FIGO type 6 leiomyoma. Since patient is young with an obese weight, so actually lifestyle change would be best for this patient. Thus weight loss is essential for this patient. Since patient has irregular menstrual bleeding, the best way to treat this patient would be to regulate her menses. So this could be in a form of combined oral contraceptive pills. Because progestin, continuous progestin-only pill, or any progestin component of the medications like levonorgestrel IUD won't make it regular. The best way to make it regular would be a combination of estrogen progestin in a form of combined oral contraceptive pill. So this patient has AUB-L for leiomyoma and sits type 6, which is outside the endometrial cavity. So it's considered as O or others. Then we also have ovulatory, which is because of the irregular menstrual bleeding. Okay, another case of a 38-year-old G2P2 6 months intermenstrual bleeding. So there's bleeding in between her menses. FIGO type 4 and 5 leiomyoma. Hystersonography, we showed an 8mm polyp. So the leiomyoma is really not part. When we talk about submucous myoma, it's between FIGO type 0 to 3. That's part of the submucous component. It has a submucous component of the leiomyoma. 4 and 5 is already considered as intramural myoma. So it does not specifically, if it's not large enough, it doesn't really have any effect on AUB. And on sonography, it showed the presence of a polyp. And this can be the reason for the intermenstrual bleeding for this patient. As we've mentioned earlier, polyp cannot be treated medically. It's best treated surgically. And the best way to treat that, to do the operation, would be to doing a hysteroscopic polypectomy to have a direct visualization of where the polyp is attached. Now for this case, 35-year-old G0 with heavy menstrual bleeding, patient has persistent anemia with unexplained bleeding with worsening dysmenorrhea. Patient is diagnosed with adenomyosis and von Willebrand disease. So for this patient, it would still be best. For this, we have to fight anemia and to prevent having profuse bleeding. The best way is to stop her menses. So less side effect would be using the levonorgestrel intrauterine device. So with this, I hope you have an overview or you have been updated on how to diagnose, check into the possible causes of AUB using the palm coin, and management of AUB. Thank you, everyone, for listening.
Hello. Hello, and good afternoon again. Thank you, Dr. Midizo. That was a comprehensive, very, very practical discussion for AUB. May I ask our tech team, is my audio coming clearer now? Oh, okay. Let me make an adjustment.
All right, how about now? All right, so great. So I will be answering some of the questions that have popped up in the chat box today because of schedule conflicts. No, Dr. Midizo has asked me to be available for your questions, and I hope I can be able to answer. So some of the other questions have been typed in. So I have we have a question here. I experienced AUB 2 months ago and lasted for 1 month. My CBC, except hemoglobin and transvaginal ultrasound, appear normal. Only retroverted uterusine. Are there any other tests that could help identify the reason for the AUB? Yes, because in the process of evaluating for AUB, it's not only the CBC and the transvaginal that is important. Like in the discussion of Dr. Amigizo, there are two entities. One is the structural, no, which would help be answered by the transvaginal ultrasound, but the other group of problems will not be answered by that. So yes, there has to be an expanded investigation to help identify the cause of your AU. Is there benefit to use micronized progesterone and evening primrose oil for AUB? And what is the recommended daily dosing regimen? The use of micronized progesterone and evening primrose oil is usually in the context of a postmenopausal woman. Those are our pharmacologic agents that we can utilize in what we call the menopausal hormone therapy. So that would be outside the boundaries of this, and would actually constitute already another topic for discussion. But those two medications are usually offered as part of menopausal hormone therapy for women above 50 years old and have not been experiencing menstruation for at least 1 year. Okay. All right, I think this next question is also related to that. Does the assessment protocol change? Example, for a patient who is postmenopausal, 2 years postmenopause, who has had bleeding that resolved for 3 days, is pharmacologic management still necessary if the patient refused for diagnostic exam, such as the transvaginal ultrasound? Yes, ma'am. And if I would highly encourage for you to undergo an evaluation, because for postmenopausal women, any form of bleeding, whether it's light or it's heavy, or it was there and then it stopped, it warrants an investigation. So I'm sure if you go to your obstetrician gynecologist, she would be able to help you try to find the reason for that. So please do have an evaluation. What else? So I am a 32-year-old. I think I can answer this as a last question. I am a 32-year-old. Oh, what happened? Nawala. That I think I answered that already. Okay, what else? Can micronized progesterone, 200 milligrams as a vaginal suppository, be beneficial in the acute management where bleeding is still heavy? No, because the micronized progesterone, 200 milligrams, is administered intravaginally. So if you are still bleeding heavily, then it will just wash off. No, there will not be enough time for the medication to dissolve and be absorbed by the vaginal mucosa if you are still heavily bleeding. So your obstetrician gynecologist might opt not to give you an oral medication, or if the bleeding is really very heavy and very acute, an intravenous route may be offered to you. Okay. Is in remote settings where immediate transfer to a facility where ultrasound is not possible, for how many days can we safely prescribe tranexamic acid and mefenamic acid? Is it just 5 days? Will it not affect ultrasound findings? So like in that particular slide that Dr. Mizo has shared with us, yes, tranexamic acid in combination with mefenamic acid are very safe to use, especially in the management of acute heavy menstrual bleeding. It will not change the pathology. So whatever is identified, it will not change. It will only target the heavy menstrual bleeding episode. And usually the maximum number of days that can be offered is about 5 days. So tranexamic acid that's given 500 milligrams every 8 hours or 3 times a day for 5 days. The same with mefenamic acid, which is 500 milligrams per tab every 8 hours or 3 times a day also, but after meals, so that we will prevent gastric irritation. Okay. Oh, of course, I would like to be able to share this. We have an attendee who said, thank you for the comprehensive lecture to all patients. We'll give tranexamic acid and mefenamic acid. Oh, yeah. Yes, I think I answered that in that question. So thank you very much for everybody who has signed in this afternoon. And I would like, now at the end of our open forum, of course, we'd like to thank our sponsor, Biopharm, for helping make this webinar possible. Class 1998 would also like to thank the following who helped this webinar possible: the University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and of course, our sponsor, thank you for this webinar, Biopharm. So we invite all our viewers to join our next webinar on management of hypertension. Our next expert speaker is Dr. Jude Eric Cinco, a cardiologist, intensivist, and an assistant professor at the Ateneo School of Medicine and Public Health. He is also a member of the UPCM class 1995. The webinar will be held on September 15, Friday, also at 12 noon. You can use the same Zoom link to register in advance or use the QR code shown here. So to receive your attendance certificate, kindly answer the evaluation form, which you can access through this QR code shown here. We will also post the URL in the chat box now. You will be able to receive your attendance certificate only after answering this evaluation form. Please ensure that the name that you enter in the form is the name format that you want to appear in your certificate. See you next time as we continue to unlock knowledge for primary care workers and allied medical professionals. God bless you and stay safe.